and that's the issue with functional control with what you've got left. And eventually, if that functional control stuffed when they're walking, then they'll get the calcification of bone build up on the dorsal of the joint, which gets your hallux limitus, and eventually some other form of first-ray defect.
Is that called Jack's test?
Yep.
Yeah.
Jack's test, windlass test, stick the big toe up in the air test, whichever one you want to call it. Yeah. I mean, I think Jack's test has been flouted now. It's more in vogue to call it that now.
So is the test an actual test that they do, or is it we do it?
No, you can do it. You do it. They wouldn't have a clue. Yeah, I mean, patients aren't the clueliest people on how to look after feet. That's for sure.
So you're testing the range of motion.
Yeah, the best way to do is test it. Is you test it off the ground so you see what actual range of motion the joint's got. And Jack's test is when you put it on the ground and you try and lift it up without reefing it. You should be able to come up with just a reasonable amount of force. If it doesn't come up, you look at it, you get 5 degrees, 10 degrees, and I don't care whether you measure it or, thumb thickness is about 10 degrees, half a thumb thickness is 5 degrees, but you're looking at that. Then you supinate the subtalar joint and then again flex, right, the toe. And if you see increase of range of motion, then you know there's a mechanical defect there and something's creating that restriction. If it's restricted in both modes, you may find that you've already started to get osseous changes and you may have some restrictions in the joint itself. And that doesn't mean you can't get it back. I don't know, most of you are soft tissue people, right? Don't mind giving patients pain occasionally with a smile on your face, and that's what you need to do. Sometimes you just need to get into that joint and you start getting some of that range back and you can actually get it back. Orthotics aren't a cure-all. They need to take the stresses away properly, and then you need to get those joints working properly again. And sometimes that's the case. And if a patient can't do it themselves, then sometimes, obviously we've got a pair of hands, so we fiddle occasionally, or I've got a massage therapist next door, so she gets all my all the stuff I don't want to do because it takes too long. And obviously there's lots of other specialists that you can use. Physiotherapists, I probably wouldn't use a physiotherapist for that as much because they don't have the time in their practice. They've got other things to do, so I'm probably more likely to use a massage therapist, chiro to a degree, or osteopath, or anybody that knows how to move that properly, because it's a time thing. You really need to spend a lot of time on it. And I really like practitioners that actually teach their clients how to do a little bit of it as well, so that they monitor it and they keep working it, because you don't work it. Because you've got to think too, and that first ray's one of the most important joints in a foot. You got to think they've probably been screwing it for about 20 years, 30 years, 40 years, and one treatment's not going to fix it, and they have to be made aware of that. So they might need another 20 years of treatment to get it back to full range of motion. It doesn't matter how long it takes, as long as you can. I mean, X-rays will tell you whether there is actually so much damage that they won't get it back, and it may need to be surgically fixed, but a lot of them aren't to that level.
My question to that is, if you have surgical repair, how do you change the orthoses to suit that fused joint?
Well, one, you hope that the surgeon doesn't bloody fuse it in the first place, right? Hopefully, because the reason they don't chisel it off, right? It's not hard. It's only carpentry. You get in there, open it up, chisel off the joint that's excessive, repair it, and leave it alone. Now, it'll grow back. I know that. They know that. But if you're doing proper therapies and you've reduced the stress on it, and you're actually keeping the motion there, the likelihood of it growing back, and this is anecdotal, is a lot less, has to be a lot less. So why would you cripple a patient up that's 35 or 40 with a arthrodesis when, okay, if 20 years down the track it's stuffed again, then we can do the arthrodesis.
So how would you change the orthotic to suit that?
Probably look at a plantar flexed divot in the front. So it used to be called the old plantar flex, plantar flex first ray cutout.
So you give them some space for that joint to move.
And the way it's got to be done though, you've also got to shift the pressures to make the other areas of the foot work as well. So you might take some stress out of that and increase the stress on the other side. You know, not all bunions are the same, so you also got to look at the forefoot deviation. Is there, you know, is it a 2 to 5, 2 to 5 0 with a plantar flex first ray or a dorsiflex first ray, which is what we're probably talking about there, or is it actually a forefoot valgus where the forefoot's been deviated for years, but first ray's been shoved up, so now we need to get that forefoot even to the ground? Is it bunion formation where fifth ray and the first ray gone, so they're both dorsiflexed and the transverse arch has gone and it's sublux? So all that's got to be compensated for as well. So it's not just a matter of bringing the first ray down, but yeah, if you don't bring the first ray down, you're not going to get the function.
We've also found that when they're fused it, which I can't believe they do.
It's easy, it's quick, and the toe's not painful after that, as long as you don't walk.
They're not allowed to walk on it, right?
Yeah.
For ages.
Yeah.
And then you've got to get that gait going again, and they've got all sorts of multiple problems. That's why they've ended up with the friggin' toe in the first place. And then you can't even get them back walking properly again.
But it only takes 5 minutes to do. I get paid and I don't have to look at it again. You know? I mean, it's, you know, orthopaedic surgeons have great skills for certain areas. Feet, you know. If the foot's stuffed, then yeah, go in and surgically correct it. But if there's any chance of doing some other therapy, they shouldn't be touching it. And most, you know, some of the orthopaedics I've got working with me now, they won't touch it before I have a go. And then they might do surgery 10 years later. But the patient's got to be aware that, you know, your foot's going to be stuffed again eventually anyway. So you don't, this is not a cure, it's a fixative process. But you're right. If you're 35 and they ask to reduce that first ray, you can forget your knee and forget your hip eventually. Right, it's just a thing. But then, okay, well, let's go down the boot ways and let's make these nice clodhoppers with a nice rocker bottom on the bottom, and your patient's going to wear them every day. Bullshit. You know? They don't want to wear that crap. So you've got to compensate for it. So you look at some of the more, I mean, the shoes cost a fortune, but some of the shoes like even Rockport's Cumps and things like that, if you watch the toe angle, they're lipping the toe up a little bit further so that the shoe does a bit of the work rather than the foot doing a bit of the work. But no one's going to be rocker bottom shoes in their right mind. They work, they solve the problem, but they're not going to wear them. You know, I've got patients that don't even like wearing their orthotics sometimes, and women are the worst. Well, I mean, you know, you look at an average woman at an average age, you know, I don't want to start wearing rocker bottom shoes. I mean, I've got teenagers that are in tears because they've got to wear crap shoes. It's not a good life, but you know, sometimes you get to that point where you've got no choice to advise them that. It's still their choice in the end. It's their feet, their body. Right? But you have to give them the information, I agree. But if they're not going to do it, then I've got to find some other way of keeping them going for as long as I can, under the explanation that they know that they're forward to problems. Sorry, yeah?
What about the new sketches?
The new what?
Sketches.
Sketches, yeah. I mean, look, you know, MBTs, sketches, whether they're a rip-off of MBT, whether they're a rip-off of the 70-year-old, 80, 100-year-old rocker bottom shoes, you know, they've got a bit of padding here and a bit of there. The effect in the end is the same. It increases that forward motion, makes you more unstable. You're on unstable ground, your ankle will go eventually. You're up in the air and you're rocking. So if you don't have the muscular control to control the shoe, you'll go A over T eventually. But they do have the effect. They make your stomach muscles work harder. They can make your back relief a little bit because they're rocking you, so you're making your muscles work. And I think with the MBTs, they go right into teaching you how to walk with it too, with videos and all that sort of stuff. But in the end, and I had a patient that wore MBTs, still had problems, come and saw me, I put orthotics on it. She can't wear her MBTs anymore.
I was going to say, can you wear MBTs with orthotics?
It's the only way I could wear mine. and they're still sitting in the cupboard there. I use them occasionally, but it's you know, and these things are they're a new one by I can't remember, but anyway, they've got just an increased toe, so you can feel it when you walk, but they're all relative, looking on trying to change your gait. And the bottom line is that your foot's different to her foot and it's different to your foot. So a size 8 MBT is not going to solve all your problems, you know. But I think, according to the blurb, it pretty much cures everything from constipation to whatever. So, sorry?
And they're supposed to make you look good as well.
Yeah, well, they're trying, but it'll make you taller. You want to ask a question?
Yeah, I just want to ask a quick question. Back to the orthotics.
Yeah.
If with something like this, how often would you have to reassess and check that it's working? Like, what's on average?
It's relative to the patient, but if it's a child, could be 6 monthly, 12 monthly. The orthotics might get replaced every 2 years, but they do need to be tweaked. I mean, orthotic to me is like, it's made properly, it's like getting your car wheel alignment done. You got little pieces of metal on the wheel. Sometimes the steering wheel starts to shake, you just need those adjusted. Same with the orthotic. The orthotic will not go through for the next 30 years without needing some form of tweak. And unfortunately, some of my orthotics last that long, so trying to convince the patient to come back when they feel good's hard as well. But on an adult, 12 monthly to 2 yearly.
What about just initially at the start?
You know, my base would be, well, you've done your examination, you've decided what you're going to do, you've explained everything to the patient, and so then they decide, fit them with some form of orthotics. I do a lot of prescriptive work because that's what I'm good at and that's what I get referred. So once I do that, we give them their instructions on what to do, what not to do. Some of them, you know, hour on, hour off. Some of them, shut up and put up, just keep going. Some of them, it just depends on the individual. And then I check it in 8 weeks' time and then look at it in that sense to see, and I tell the patient, in 8 weeks' time I'm looking to see whether I'm happy with the way you're moving. And you give me feedback on how you feel, and then I'll decide whether we need to have some adjustment done. And some patients come back, they don't need any tuning, some patients do. Doesn't worry me. Some patients comply, some patients don't.
So while we're on that,
yeah.
Do you have an opinion on the new Barefoot technology craze at all, or what's your opinion on that?
Yeah, just add a Y to the end of that craze, right, and you're fine. I mean, if Barefoot is so good, why aren't you all running barefoot? Okay, remember, what are you running on? It ain't the grass, it ain't the back streets of North Africa and out in the desert either. So you've got to look at it, but I think it does make you work your muscles. And as I said to the Nike guy when he brought me over a pair to convince me that they worked, is that I feel, you know, they've got, I would have liked some of my oldies to have them to walk on a treadmill for maybe half an hour or 15, 20 minutes to make their foot muscles work. But you're not going to get any of them spending $250 for a shoe that they're going to wear for half an hour, maybe 2 or 3 times a week. So I think they talk about how it makes your muscles work, gives you training. They don't wear them racing and etc. because it's just a proprioception, da-da-da-da-da. Which, yeah, to a degree, but I wouldn't be wearing them all the time, and I wouldn't be wearing them for any heavy training, especially if you've got some sort of issue. So if you come to me and you've got no issues and your mechanics are within normal limits, you're going to have a great result with those. But you don't need them in the first place. So each individual, you know, you put orthotics in them, well then what's the point? The point of it was to make your foot work. So yeah, you know, I think bare feet's good for you. You need to do it, but not on the concrete. You need to go back to climbing the trees, walking on the grass, getting the mud between your toes, doing all that, which is what we don't do. And while they don't do it, it keeps me employed.